Hi, everybody. It's really nice to see you. We're going to get started in just a few seconds. While we're waiting, can you please, a lot of you already have, start typing your name and organization in the chat to say hi. And if you want, you can tell us how many summits you've been to. Um, so I personally can't believe that this is our sixth summit, which means that we've been doing this for 5 years. And yes, for those of you who remember, this means that my baby is indeed 5 years old. He just started kindergarten, which is a whole new phase. And I think the coalition is starting a new phase too. I'm so grateful to our sponsors, everyone who has supported our events, funded our research, and championed our work throughout the years. And this year, especially the Cambia Health Foundation, the John A. Hartford Foundation, Bay State Health, and as always, Blue Cross Blue Shield of Massachusetts. Thank you, Andrew. We welcome everyone to tweet as they see fit. You will find the hashtag in the chat and on other summit materials. I can't wait to get back to in-person gathering, but until then, here we are in virtual space, a little fancier than last time, to talk about what we've learned and where we think we're going. One thing we know is that equity will be the driving center of everything we do. As you'll hear today, if there's anything that our most recent research has taught us, it's that a focus on equity is not just the right thing to do, it's also an immensely powerful lens for quality improvement in serious illness care. If we focus our attention, efforts, and resources on the needs, experiences, and challenges of people most likely to have poor outcomes, we will not only improve their care, but everyone else's too. If we start by purposefully collaborating with the communities least likely to have been included, respected, and believed, our health systems will get better faster. Because while everyone's healthcare challenges are unique, touched by intersecting facets of our identities, from race, gender, age, income, diagnoses, body size, and ability, we found that what we all want and what we struggle with has a lot more in common than not. A human need for caring and connection, to be seen, heard, and trusted as part of a collaborative approach to care. And this is what clinicians want too, but boy, do our systems make it hard. And it grows harder still for people entering the system with less privilege. This is big stuff, the biggest, but I cannot think of two people better positioned to start us off on this work today. Andrew Dreyfus, President and CEO of Blue Cross Blue Shield of Massachusetts and Coalition co-founder, and Michael Curry, CEO of the Massachusetts League of Community Health Centers. Andrew and Michael, over to you.
Thank you so much, Anna, and thanks for all you do every day for the coalition and all the organizations that make up the coalition. And thanks to you and Stephanie Chan and others to put together this great summit. I wish we were there in person with you at the Kennedy Library or at some other interesting venue in Boston, but I hope it's soon that we can be with you together, because there's always been so much energy in the room. It's been described as a revival meeting. And a chance for all of us who care so much about this issue to get together. Today, I'm so glad to be here with a colleague and friend and someone I really admire, Michael Curry, who, as Anna said, leads the Mass League of Community Health Centers. He's someone who's really devoted his career to fighting both for better health and against racism and bias and prejudice in our society in a larger way. And so he brings a mix of just terrific experiences to this role. So, Michael, welcome.
Glad to be here. Glad to be with you.
So we're going to do this as a kind of fireside chat. And so I'm going to ask some questions of Michael and some things he's been thinking about to the issues that Anna just raised. But before I say that, I just want to remind you that Blue Cross as an organization has been deeply committed to this issue of equity for years. We defined it, I think, more narrowly in the past. Today we define it very broadly, and we've been recently focused, and just a few weeks ago made a major announcement to be the first plan, certainly in this market and perhaps in the country, to identify, measure, and publish racial equity disparities in the healthcare that our members receive. And so this is an important time where so many of us are kind of focused on this issue. Michael, I'm thrilled to be talking to you about it. The League, the Mass League of Community Health Centers, was one of the original 20 members of our coalition. So they were part of the planning early back in 2016. And I know that the partnership between the coalition and the League has evolved and changed over the years. And that partnership has been a big part of the strategic shift that Anna mentioned to really focus more on equity than we have in the past. So, Michael, before we talk about how we get at the health equity issue, I just want to look back for a minute. How do we get here, and what role has racism played in healthcare?
So Andrew, first and foremost, an honor and a privilege to be with you. I want to give some credit to my predecessor, Jim Hunt, who you know very well, Andrew and Anna, who had the vision to make sure that we were aligned and working with you on these issues of serious illness. We are in the middle of a pandemic. I think probably as you asked that question, Andrew, I think about the 240 million cases of COVID-19 right now, the over 5 million deaths that we're seeing across the globe, the over 700,000 deaths that we experienced just here in the United States. And I think you've gotten, as I've often used the term, weather to that death. But we know that a large number of those people who have died, who've been infected, who are still dealing with long COVID, too many of them are Black and brown. But there's a context in all of this as we talk about health equity, as we talk about racial justice. And I get asked all the time that question that you asked, Angel, how did we get here? So I start at a place that most of us don't want to go, which is slavery. And as we look at this country's history from the 1619 and the arrival of those 20 or so odd slaves in Virginia to 1865, and the end of the Civil War and the emancipation of slaves, the inadequate health care that those slaves had access to, and then moving into Reconstruction in the 1800s and the end of that century, the lack of access to health care that those African Americans had. Some folks say, well, why do we go back that far? Well, I always make this reference, Andrew. I say, it is inherently racist to believe that a population of people don't want to live longer lives, don't want healthy food, don't want access to a quality education, don't want to build wealth, and the many other disparities that we see out in society. So the reality is, how did we get here? And it is about systems. It's about systemic racism. You can't have this conversation without talking about J. Marion Sims and his experimentation on Black women, slaves, Annika, Lucy, and Betsy. You can't have this conversation without talking about the role that our medical associations played in racism, and the fact that they screened off many Black and brown physicians from practicing, from membership. You can't talk about this without having a conversation about the decades of experimentation on Black men during the Tuskegee syphilis experiment. Folks say, well, why does that matter? And I say, well, imagine generation 1930s to the 1970s. The science was that Black people were the syphilis soaked race, that we essentially had bad blood. I'm not talking about quack doctors, I'm talking about the science was that we had bad blood and we carried syphilis. And it wasn't until we realized that that experiment was still underway that it basically brought Black men in without treating them for their syphilis. And it was unethical. So people say, well, that's the history, that's the past, but what does that mean for today? I have no doubt that many of your Black and brown folks that are listening today have their own lived experiences that are 5 years old or 15 years old or 20 years old that will tell you a story about unequal treatment. As Andrew, you and I have had this conversation in the past around the Institute of Medicine's report in 2002 that reminded us, or I shouldn't say reminded us, reminded some of us that there was unequal treatment in our healthcare system. So now, come fast forward to where we are today, we're having an epiphany about all of this and how race plays into our system of healthcare and health insurance. And now the responsibility is back on us that with this awareness, how do we translate that into change? And I think that's where we are.
Yeah, thank you, Michael, for that reminder. It is very powerful, very important, and we need to hear it every time. So I'm glad you remind us of it. You know, you mentioned the 2002 unequal treatment report, and that was very powerful to me at the time. I was then running the brand new Blue Cross Blue Shield of Massachusetts Foundation. And in part as a result of that report and some other work and what I was hearing from the community, we started a program in cultural competency. We started a program in reducing health disparities. And while I think we helped some individual programs and a lot of community health centers were part of that, when I look back, I say, you know, we haven't changed enough. And that people have been working on disparities for decades. And I know there's a new sense of urgency and purpose, but what was missing over the last 20 years when we've been engaged in this issue, Michael, and how can we do it differently?
Yeah, well, I mean, credit to Blue Cross and Blue Shield, and Andrew, as you know, one, hello to my many friends at Blue Cross and Blue Shield, and the work that you've always been doing to try to move the needle on this health equity challenge that we face as a company, and even your recent announcement of the work that you're doing to try to meet the moment, as I say, around health equity. I think where we've dropped the ball is that we don't get that health equity deals with a lot of parts of our system. There have been recent studies, I think the Kaiser Family Foundation, that show that even when you get after health reform in Massachusetts or the Affordable Care Act, or as some refer to it as Obamacare, that if you expand coverage and give people Medicaid access to coverage, that still means that doesn't mean that the disparities go away. That the data still shows that those differences, those disparities still exist. So you can give people coverage, but what is it about our system that we've not really dealt with around, again, as you said in the report, unequal treatment, around access to care? We know, and it's now an often quoted statistic, that 75 to 80% of the health status of a person has less to do with the care they actually receive and more to do with the conditions they live in, the circumstances they face. That's the food insecurity, the housing insecurity, that's racism, that's the trauma. That's the lack of access to dental care and eye care. We know that now. But the challenge is how do we take that awareness and move the needle forward? And we've not done that in a concerted, joint, collaborating way to say, how do we get our health plans, our hospitals, teaching community, our health centers, clinics, our pharmacies, the pharmaceutical industry, how do we bring all of them under one tent to not be, as I've used the term, weathered to high rates of death and sickness in communities of color and in larger communities? I use this reference often, Andrew, and I want to share this with your attendees today. I say, Dr. Lauren Smith, who you know and used to be in Massachusetts, now she's at the CDC Foundation, did a presentation that I was in with Healthcare for All. And she said, Mike, I want to introduce you to the term weathering effect. She said, we came in and we asked Black parents to rate their kids' asthma from 1 to 10. And many of those Black parents, like my mother, I had asthma, my sister had asthma, rated those kids' asthma 3, 4s, and 5s. Then the doctors came in and evaluated those same kids, and they were 8, 9s, and 10s. She said, Michael, that's the weathering effect. Because you can get so used to taking the Flovent, the Alupin, to being in the emergency room like I was at Boston City Hospital every month, every quarter, bent over because you couldn't participate in gym, that you become weathered to being sick. So I say, as Anna knows, we become weathered to diabetes, weathered to heart disease and cancer. We become weathered to HIV/AIDS, higher rates in communities of color. We become weathered to trauma in communities with high rates of violence, to not being able to take care of our teeth and afford the co-pays and cost sharing that's necessary to treat ourselves. So we have this dilemma where we're not realizing that it takes an all-in approach. We can't tinker with it. We can't attack it from one side. We have to attack it from all sides. And just one last thing, credit to some Black and Latinx leaders right now that are coming together on Monday that represent many different sectors, including Blue Cross and Blue Shield, that are going to have a conversation around how do we make sure we don't miss the moment this time. Chapter 58, Chapter 305, Chapter 288, Chapter 224 on the federal level, health reform, but none of those focused on health equity like we need to. And I think we're at this point where the right people at the right place at the right time, we can do it.
Great comments, Michael. And at the beginning, you talked about, I think, this issue that we've always said that having an insurance card is not enough. You need access to equal care, and then getting the care itself is not enough if you're in a social environment, whether it's from housing or food, that don't allow you to achieve your best self and your best health. So when you start thinking, and in a minute I want to turn to the serious illness question that we're all here to talk about, but when you think about this new chapter of health equity that takes into account that weathering effect that Lauren Smith, who by the way is on our board now, spoke about, what do you see different? Is it that we're going to have communities participate in the design of the work differently? Are we thinking differently about the racial component of it? What is going to be different this time?
You know, it's interesting, Andrew. I think about, and I was there at Blue Cross when health reform was being debated, and you were there as well. And we were talking about how to advance health reform in Massachusetts. And I always tell people when I teach a course at Suffolk University, a healthcare management course, and I tell my students, I'm not sure that would have happened but for the right people at the right place at the right time, right? The right people in our health plans that were willing and ready, and Blue Cross, a leader among them, that was ready to take a leap into this place that we didn't really know where it was going to lead around health reform. I think we had the right people in government that were looking to do something different, to make Massachusetts stand out. We had the framework in Massachusetts that made health reform work, right? Less number of uninsured than some other parts of the country. Some regulatory protections that worked, guaranteed issues, and other factors that made Massachusetts the right place to make health reform. I think we're there again around health equity. When I think about Kevin Churchwell at Children's Hospital, when I think about the leadership there with you, Andrew, who've been on the phone with me and emailing me, how do we address health equity? I think about your new hire, Manny Lopes, who's been a leader in health equity from the leading by example with East Boston Health Center. When I think about Juan LaPera at BI Leahy, I think about Lee Pelton, who reached out from the Boston Foundation. I want to be a part of this movement to deal with health equity. I think we have the same element that was there in 2005. Right people, right place, right time. Can we make it work? I'm not sure. Can we all come together and really move the needle? But I think it's going to require a leap of faith, like it did with you and many others in Chapter 58. And that leap of faith needs to be there now.
Great. And I agree with you that I think we have the people and we have the momentum, and now we have to channel it in a smart way. So let's turn to the issue of serious illness. So Michael, you know, this encompasses both serious chronic illness and care at the end of life. How do you see the intersection of equity and serious illness? Is it different or the same than any other care?
Yeah, it's different. I mean, the reality is, as we look across now, we're looking at data here at the Mass League. You know, I've really challenged my team. I'm only 10 months in as CEO, and I've made that a major priority of the league, that we look at health equity, and this is taking the Blue Cross model, not just figure it out for our patients, but how do we lead as a community health center movement? Quick reference. As you know, Jack Geiger, Count Gibson were two of the founders of the health center movement. They were before their time. Quite frankly, in the 1960s, they understood it wasn't just about providing you with care, it was about providing you with healthy environments. It was about getting you clean water. It was about making sure that, as Congresswoman Ayanna Pressley, who's a friend of mine, says, she says, those closest to the pain need to be closest to the power. That means making sure that the board members who sit around your table are also people dealing with diabetes and heart disease and cancer. That means making sure that the people sitting around your table can also say, well, I'm not sure that there's cultural competence when we walk into this building, and I'm not sure that we're receiving quality health care. We need to do something from a policy standpoint. And by the way, here's my suggestion. So I think right now, as we look across our communities and the data that we're collecting, one thing struck at me, which is when we look at the populations we serve, we're serving less of the 75-plus-year-olds. So when I asked my team, I said, what does that mean that we're serving less of that population at 75 plus? And some of the team said a major factor in that is because they're not living long enough compared to their white counterparts. Our patients are dying by the time they reach 75 plus. So we think about reaching that 75 plus population. I was on the governor's COVID-19 working group to figure out how to prioritize the vaccines. And I remember lifting up with Chair Cindy Friedman, who's a phenomenal leader, good friend now, lifting up with Liz Walker, Reverend Liz Walker, and others. No, we need to make sure that we do this equitably, because many of our communities don't live to 75 or 80 or 85. And therefore, if you prioritize 75 plus out the box, you're going to miss our people, our communities who are closest to the pain. So I think, as Anna knows well, I'm in many talks, cancer, By the time we find out we have cancer stage 4, there's very few interventions that's going to save your life when that disease is gone that far progressed. I've been on calls with Dana-Farber and others around what are the right interventions and what can we do and work with them. We've been in conversations around diabetes and what we can do to reach our communities that are desperately losing their limbs and their lives. Recent study came out showing, and I forget where the study was, I want to say it's Maryland, the number of Black families that are losing limbs at a higher rate than white families. Recent study, just Google it, came out within the last week. So we have some work to do around serious illness, around the impacts of equity and serious illness, because we all, not just African Americans, not Latinx, not Asian communities, we've all been weathered to the fact that we're losing a population of people to these diseases unnecessarily. And I think, of course, Andrew, as you know, this impact on all this, the lack of wealth, lack of talent, lack of investment, broken communities, broken families because we're losing lives. So there's work to do.
Yeah, one of the issue occurs to me, Michael, that we've learned in our kind of 5 to 6 years here is that one of the most important ingredients is our clinicians asking their patients about their own values, beliefs, and preferences, and not assuming that they know it, and not assuming because of their income or their social status or their race or their religion or anything else that they should assume it, and that they have to sometimes work at it. And different patients will respond in different ways, and by different age, and given the kind of history of racism that you described at the beginning, it's understandable that some patients are going to be skeptical that the clinician has their best interest at heart. And so I think we have to work on that. We only have a minute or two left. I just want to talk for a moment about accountability here. I think we're going to make some progress, as you said, on health equity. I think we have this kind of moment, and I know the coalition is committed to building it deeply into our work, and you'll hear more about that today, but Anna said that at the start. How do we make sure it sticks this time? How do we make sure this is not a passing moment, and then 3 years from now, we have another big health crisis or a different issue emerges? We'll be talking a lot about climate in the next decade and other political issues. How do we make sure that the health equity work we get started both in the coalition and more broadly in Massachusetts really lasts?
Yeah, I use a racial justice point when I have talks. I talk about the compass, right? That we all have to adjust our compass. And that compass is, if you read a lot, if you understand the data, then it drives you to do the right thing, right? And I'm not talking about your gut. Your gut is different than that. Your compass is tuned, is adjusted based on what you read and what you know and who you talk to. What I worry about is I asked the question of Lee Pelton and some other Black and Latinx leaders. I said, is this a moment or a movement? Broader than healthcare, but is this a moment or a movement in this context? And I'm not sure yet, right? I think that this is fleeting sometimes with the work we do. But what I'm optimistic about, Andrew, that makes me feel like it could be more the moment, the movement, I should say, is that people now understand that we're losing lives, that there will be another pandemic. There will be more natural disasters. There will be other occurrences, public health crises, and we will lose more Black, brown, immigrant lives disproportionately. And that is in all of our best interest to adjust our compass. So it's not whether I live in Roxbury or Southside Chicago or North Minneapolis in that Black neighborhood. I need to care because I care about people. Because I want people to live their full lives in a healthy way. Now, if we can adjust our compass so it's not about them and us, then we can get there. But I think we still have to pull ourselves away from this tribal approach that it's about other people and their conditions. Why don't we pull the pants up, stop eating pork, stop shooting at each other, stop doing all. No, it's about all of us. How can I help us solve the challenge that we're facing around serious illness, around morbidity and mortality rates? I think, Andrew, through the work that Anna's doing, you're doing, and the folks at Blue Cross and many others that I'm now in conversation with, I feel confident that we can make this a movement.
I think that's such a great way to characterize it, the moment versus the movement. And I think everyone in the coalition believes we're part of a movement. And I think part of the message of today is we have to make sure that health equity is central to our movement that we do together. And I must say, Michael, hearing you today, as I have recently, gives me a lot more confidence and optimism that we'll succeed in this movement because we have leaders like you who are part of it. And so thank you for being here today. Thank you for all the work that both the Mass League does, but also that the health centers of the Commonwealth do every day, taking care of the poorest and most vulnerable people in Massachusetts, and they just do an outstanding job. So thanks again. And Anna, I'm gonna hand this back to you.
Oh, thank you, Andrew and Michael, for that discussion, for making the time, for the amazing work that both of you do, and for being supportive of the work that we are doing collectively. I think building on the shoulders of giants is the feeling I was having as I was listening to you both talk, and I feel really fortunate to be able to be in conversation with both of you on these issues and bring it back to the wider conversations we have throughout the coalition. So, it sort of seemed clear at this point, our theme of the day is equity, and every day actually at the coalition. So I wanted to give you a little bit more insight about what that's meant for us so far. One example is our public policy working group that grew initially out of conversations with Pat Kelleher at the Home Care Alliance, and then Lachlan Foro, recently retired from the BI, and of course forever chair of the Massachusetts Expert Panel on Improving End-of-Life Care, which was done in 2010. Lachlan and I talked about something like a 10-year anniversary report in early 2020, but then the pandemic. When we finally kicked off in the summer of 2020, the world had changed. So here are some of the wonderful folks who join us at most meetings. Thank you, everyone who comes and contributes. We already had something of a big list of potential policies and ideas that we could focus on from the 2010 report, but was that list complete? Of course not. And how would we choose what mattered most? We can never do all of the things. And we know that these kinds of recommendations are most influential when you pick a small handful of things to focus on. So how would we prioritize? Well, of course, with equity. This is our draft prioritization rubric. You can read more about it. This obviously doesn't have a lot of details on the public policy working group page that recently went up on the coalition site. You can see we're explicitly centering equity, impact on people the most likely to have poor experiences and outcomes. And we're being really mindful about the way we think about impact and how we measure it. For example, public health and equity focused interventions often show impact on a much broader scale and over a longer timeline. So thinking about what high quality evidence really means is really important when you're thinking through this frame in a different way. And we're going back to square one with developing that big list too. So this is our overarching process. It's about listening differently and collaborating differently. So in partnership with our wonderful working group members, thank you, we're conducting focus groups with interpreters, ASAP staff members, chaplains, and more. And of course, we're leveraging this year's public experience research too, which was designed specifically to fuel this process by oversampling communities of focus, Black, Latinx, people with serious illness, disabilities, and their caregivers, to ensure that we can capture the rich experiences, not just between demographic groups, but within them too, expanding that feeling of us. But we still have so much work to do to ensure that the voices from the community aren't just being listened to, but are actively leading this work. I think Michael said it best. How do we ensure that people who are closest to the pain are closest to the power? We recognize that there is privilege in even being able to attend volunteer working groups like this. So it's part of our goals moving forward to continue to improve representation in all our working groups, projects, and decision-making conversations. We took that spirit, that kind of general acknowledgement, into our research this year too. So let me tell you another short origin story as an introduction to this work. If you all were here with us in 2018, and I've been monitoring the chat, and so the first person I saw that's been to every single one of the summits, or at least that I saw, was Alexis Levitt. Yay, Alexis. If you were with us in 2018, you might remember the results of our tracking survey that year. We found no change in healthcare proxy completion rates. We were not meaningfully different than the rest of the country on anything we could measure and compare. In truth, these rates have stagnated nationwide for almost as long as anyone's been attempting to measure them. Widely documented disparities by race, ethnicity, income, and education remain too. We also knew that there was a lot of confusion about the language we use to describe the broad bucket of activities we collectively call advanced care planning, and that the public almost exclusively associates all of it with the very end of life and death. So we changed tack. In 2018, we embarked on a messaging research project to better understand how the public hears the language we use to describe advanced care planning. and to create simple, universal messaging concepts to promote engagement, especially among those people least likely to do it. Makes sense. We were also hoping to find messaging that would encourage people to do these behaviors earlier. One thing that everyone seems to agree on is that these kinds of conversations, advanced care planning behaviors, are happening far too late in an illness trajectory to really affect and improve and reduce avoidable suffering. So we explored language that avoided reference to end-of-life care and death as an experiment to see whether we could shift that frame upstream. We tested different calls to action, from completing advanced directives to talking with loved ones and doctors, as well as the many reasons why people might do these things. The resulting research produced clear, actionable recommendations and tactical language that you've all probably heard about 400 times by now, so I won't say it again. The research also produced a wealth of knowledge about approaches and language to avoid. And I will remind us of this one because it's important and continues to be. The use of loved ones, for example, felt alienating to a small but persistent minority of people who don't have close family members to choose as proxies, and as a result, feel alienated from the entire process. The results also highlighted again the power of that end-of-life mental trap. For the younger and healthier, or even the seriously ill who are still in active treatment, they just didn't think they were there yet. But the biggest red flag, honestly, was the basic believability of what we were asking people to do. For example, the idea that people would engage in advanced care planning for peace of mind was actively rejected by some, notably those with lower incomes. They noted that conversations cannot ease the worries of affording care, taking time off work to be a caregiver, the pain and anguish of watching a loved one suffer. Planning cannot ease the burden of unmet needs and inequitable treatment. The message back to us was clear. We cannot overpromise, and we must acknowledge how these calls to action butt up against the reality of interacting with the healthcare system, especially, but by no means exclusively, for marginalized and underserved communities. In the end, this research left us with more questions than answers. Then COVID, and the questions became clearer. In 2018, we asked, how can we best promote advanced care planning to the public? But what if that was the wrong question? What if the right question is this? What are people's lived experiences in healthcare settings, the challenges they face in dealing with serious illnesses, and what does that understanding tell us about what we should prioritize saying, doing, and asking them to do? And what if improving serious illness care is less about what the public should do, which implicitly offloads responsibility onto them, and more about what health systems should do, which is in the end where the power for change truly rests. This is not saying we have to wait for the perfect healthcare system before we can do anything. We just have to move forward acknowledging reality. We designed our research frame with this in mind, and we did it really differently than our past. So this year, the first step we did, and it took a wonderfully long time, which is exactly what it should have. We started by listening and developing new partnerships. We started with the community. A full set of thank yous and attributions is in the slide in your session materials, as I honestly cannot possibly list them all. But ultimately, we knew we wanted to ask different questions in different ways. So we asked people from the community what to say, what to emphasize, how to treat the people who would be answering our survey questions and interacting in our community forums. And we kept on circling back and following up and circling back and following up. And if advice like this wasn't part of a person's job, we paid them for their time. This is by no means perfect, but for us, it's a really important step towards participatory research designs. So now you've heard enough from me, and it is my enormous pleasure to introduce Corinne Davila, a palliative care physician at MGH, who we first met while she was doing her MPH at the Harvard Chan School of Public Health as a Commonwealth Fund Fellow in Minority Health Policy. She helped lead this research as part of her practicum project, and Corinne is going to give you the major highlights from the quantitative survey. So over to you, Corinne.
Thanks so much, Anna. So to kick off, let me just tell you a little bit more about our survey. We sought to understand the experiences of a national population as well as a Massachusetts sample. We had just over 1,850 adults respond and a similar sample for Massachusetts. Reflecting on what we've heard from Michael and Andrew, we knew it was particularly important to understand the perspectives of certain demographic groups and marginalized communities, including Blacks, Hispanics, older adults, people with serious illness, disabilities, low income, as well as caregivers. So we oversampled these groups. The survey was fielded this April and May via NORC at the University of Chicago using their AmeriSpeak panel, recruited to offer a representative sample of the US population. They used a hybrid of online and phone data collection and conducted the survey in both English and Spanish. We wanted to understand how to improve serious illness care. So we asked ourselves, What makes good serious illness communication? It requires a patient who's willing to speak up and share what matters most to them, and a clinician who's willing to first ask and then truly listen to the patient in front of them. Our fundamental hypothesis is that people's experiences of being listened to in the past will influence how much they'll be willing to speak up when it truly matters. In other words, one of the most important ways to improve serious illness care is to address listening and communication well before they're diagnosed with serious illness. That's why here in our survey, we wanted to explore people's healthcare experiences, asking questions on their feelings of being heard and understood, included in decision-making, and treated with dignity and respect. We designed these questions, as Anna highlighted, with input from community members, and then pressure tested them through cognitive testing, a process by which 8 individuals from our key demographic respondent groups took the survey to check for question readability and understandability. Lastly, we asked about traditional advanced care planning behaviors to be able to compare the results to the 2017 Kaiser Family Foundation National Survey on Serious Illness, and in turn to our own 2018 Coalition Survey. Allow me to caveat, we surveyed both the national group and Massachusetts residents. By and large, Massachusetts data reflects the national data, so I'm showing you national data here, but I'll highlight specific areas where Massachusetts stands out. As we embarked on this effort, we reflected that defining the population of individuals with serious illness is not straightforward, despite us being the Massachusetts Coalition for Serious Illness Care. We began looking at different sources. How did Kaiser define it for their survey on aging and serious illness? How do palliative care researchers define it in the literature? How do clinicians think about this in day-to-day practice, apart from that, I know it when I see it, feeling? After much thinking among our group and thoughtful feedback from our partners, we settled on a twofold definition. An individual with a diagnosis of diabetes, lung disease, heart disease or stroke, cancer, dementia, depression, anxiety, or another serious mental health problem, or chronic kidney disease to start. And importantly, who reported that they've been feeling sicker or that it's been getting harder to do their normal levels of work and activity. We felt it was important to have both pieces, the diagnosis of illness and the sense of decreased functionality. In our survey, we found that 19% of individuals have serious illness by this definition. To mitigate the potential underrepresentation of individuals less likely to complete surveys, we specifically included caregivers to ask them and better understand, if at least by proxy, the experience of their care recipients. This data is not included in today's presentation, but will be shared in the future. So now diving right into our findings. What it means to provide high quality care is complex. So we asked our survey respondents how important they felt it was for clinicians in general to know their patients' priorities and what's important to them in order to provide high quality care. An overwhelming 87% of all respondents felt that it was important for clinicians to know this in order to provide them high quality care. Next, focusing on people with serious illness. We know that people with serious illness will interact with the healthcare system more often, and they were in fact more likely to say that they have a clinician that knows them well as compared to people without serious illness. However, when we asked them how well their clinician knows specific things about them, we found something curious. People with serious illness were actually less likely to report that their clinicians knew their life priorities, activities that bring them joy and meaning, and health goals, about a 10 percentage point difference, while their knowledge on other aspects like financial situation, religion, spirituality, and culture were comparable. I believe it's likely that people with serious illness have a higher standard. Perhaps they've spent more time thinking about their own life priorities and health goals, and now in turn they hold their clinicians to a higher bar. The unfortunate reality, though, is that for the very people for whom it's increasingly important to feel known, they perceive to be less well known on the very things that we believe are most important. By contrast, there were relatively few differences in other demographics. So going back to our hypothesis, we really wanted to understand people's healthcare experiences. We started with what we learned from patients and community organizations. We looked at the literature. For example, recently, the Kaiser Family Foundation partnered with the Undefeated for a survey on race and health. We engaged various stakeholders, including advocates and members of the communities themselves. We designed new questions. We asked about a set of both positive and negative experiences. So as an example, positive experiences like being listened to, treated with dignity and respect, and included in care decisions. Negative experiences like being afraid to ask questions or disagree, being talked down to or treated unfairly. We believe these experiences, in turn, influence how they engage in healthcare moving forward. You will likely not be surprised that our Black and Hispanic respondents, those in the lowest income bracket, and those with serious illness were all less likely to have these positive experiences and more likely to have these negative experiences. For instance, we asked respondents how often have they been afraid to ask questions, speak up, or disagree with doctors or other health professionals because they're worried it will impact their care. The sense of fear was something we wanted to understand. We found striking differences for people with serious illness who experienced it twice as often as those without. And just as reference, these figures are for respondents who said they experienced this most or all of the time. We also saw that people from the lowest income bracket were over 3 times as likely to be afraid to ask questions as those from the highest income bracket. To share another example, we asked how often people reported being talked down to or made to feel inferior. So let me just pause for a moment. Being talked down to or made to feel inferior is clearly a negative experience. I would go so far as to say this should be a never event, something clinicians can resonate with. Yet, we found people with serious illness were more likely to have had this experience. We can also see that by examining by race and ethnicity, that Hispanics and Blacks were much more likely to have had this experience of being talked down to as compared to their white counterparts. When asked whether or not they had ever been treated unfairly in the last year, 15% of our survey respondents said yes. So we asked them why. What we found was that there are many parts of our identities that are marginalized, and people feel them in the way that they experience healthcare. For example, the top reasons people reported being treated unfairly was due to age and illness. But there were many other reasons, like race and ethnicity, income, whether or not one has insurance, as well as things like weight, appearance, and beliefs. We also noted that for people with serious illness and people with disabilities, they reported experiencing unfair treatment at double the rate, just over 30%. Next, we began to re-explore advanced care planning behaviors, including conversations with family and loved ones, conversations with clinicians, and documentation. Now, as Anna alluded to, we understand from our own research that for a small minority of people, using the language loved ones is not the best. That said, in order to track questions against our own prior survey, as well as the Kaiser Family Foundation National Survey, we asked these questions in the exact same way. The next few slides I will show you are chock full of data, but we also want you to have this as reference for when we break out into discussion a little bit later. So to begin, when we think about the larger context, we knew we were asking individuals this year, 2021, with the backdrop of the COVID-19 pandemic, where popular media was encouraging and reporting signals of large upticks in conversations. Yet what we found was that despite the attention of the pandemic, conversations with loved ones and documentation was largely flat. Some small increases and decreases, but largely flat in both the US and Massachusetts. By contrast, conversations with clinicians about wishes for one's medical care did increase, modestly in the US from about 18 to 23%, but more notably in Massachusetts from 14% to 32%. So that's right. The last time we asked, we were kind of more in line with the nation, but now we're really starting to edge forward in having these conversations. And we believe these increases really reflect the work that so many of you and others have been doing over the last years and also during the pandemic. It is worth noting here that we asked people who had not yet had a conversation with a clinician whether they would want to. And we found that in the US and in Massachusetts, people who had not yet had these conversations were actually now less likely to want to talk about it as they were a few years ago. Next, we looked at how people with serious illness engage in these advanced care planning activities. We see that people with serious illness are more likely to have had conversations across the board, but the rates are still relatively low. For example, only about a third of people with serious illness have had conversations with a clinician about their wishes for medical care and who will make decisions for them. Interestingly, rates of documentation for people with serious illness were actually the same as people without serious illness. Now, this is a particularly busy slide as we're looking at 3 different dimensions here: the different categories of advanced care planning actions by race and ethnicity over time. So just to share a few highlights, what we see is that racial and ethnic disparities persist in advanced care planning engagement from 2017 to 2021, and some have actually grown. In particular, if you want to recall that we asked respondents who had not yet had a conversation with a clinician whether they would want to, we saw decreases overall. And now when we look at the data broken down by race and ethnicity, we see that the differences are largely driven by notable decreases amongst Blacks and Hispanics, who had about a 20 percentage point drop in willingness to engage. What this underscores is really how much work we all need to do to reach these marginalized communities. So as we looked at a whirlwind highlight of the quantitative survey results, and I will frame that this is just a highlight. We have much more that we're still continuing to process and look forward to sharing. A couple of things stand out to me. First, it's clear that all people seeking care are asking for a connection, a clinician who listens to them, who knows them well. And as a clinician myself, I know that clinicians want the exact same thing. However, both patients and clinicians alike are working in a healthcare system that doesn't facilitate prioritizing this connection when there are a multitude of other competing priorities in a time-limited visit. Second, in order to strive for equity, we have to think holistically about how people are being treated when they're getting healthcare. From the moment someone picks up the phone to schedule an appointment, greeting them at check-in, all the way through to the clinician's visit. As Michael and Andrew spoke about, just having the insurance card isn't enough. It's about all the rest that follows. So improving people's experiences is how clinicians and systems begin to build trustworthiness, giving people a reason to trust us to give them the highest quality care. We hope that this gives you some food for thought and that you'll be able to talk more about this in your breakout groups. Thank you. Back to you, Anna.
Thanks, Green. Obviously, some real cause for optimism in some of those findings, especially in the Massachusetts clinician conversation data, but a lot of other places, I think we'd all wish to do better. It's always amazing knowing something and then seeing the starkness of the figures on the page. I think, changing those experiences I'm seeing in the chat a little bit, this is beyond individual clinician action. We're talking about systems and policies that support these on a much broader scale. And one of those things is obviously skill building, which is not news to anyone here, but for the past 4 years, we've been working on 2 initiatives that sort of reflect the importance of really including these skills in all training. our Medical Schools Collaborative, and our Nursing Task Force that are each assessing and reflecting and endeavoring to improve the skills and competencies that our nurses and doctors graduate with. Both projects have had really eventful years despite the pandemic. The nursing schools fielded a bachelor's curriculum survey. The medical schools completed curriculum mapping projects and student experience focus groups. Thanks as ever to Jen Reedy, who heads the Medical Schools Collaborative, and Susan Lyside-Hurley, who co-chairs the Nursing Task Force, for making all of this go. And I just want to play you a short video, listening from their voices and a few other people to reflect on what they've been up to.
I was most surprised by how varied my classmates' experiences were when it came to topics like palliative care and end-of-life care. My fellow classmates have been exposed to a wide variety of attitudes toward palliative care, depending on the services that they rotated on or the attendings that they worked with. There was also a lot of variation with regards to exposure to family meetings and goals of care discussions. I was able to compare my own experiences with my classmates' experiences since I was also a student. Well, I did get a chance to spend a day with the palliative care doc doing home visits. I never really got a chance to do goals of care discussions or family meetings or participate in anything like that.
One thing that surprised me most in working with the collaborative is realizing that students want this training. I heard students say that they wish they could sit down with someone to observe their communication and dissect their language to understand what's most effective and what isn't. Students want to be included in these conversations and don't want to feel like they're asking for something that isn't part of their curriculum. Recognize that in their rotations they are told that they need to figure out the goals of care and that they wondered, how do you actually identify a patient's goals of care, and what are goals of care, and how do you actually structure a conversation or a family meeting in depth to make sure that patients feel comfortable telling their truth.
I think one thing that surprised me about our work together, the 4 Massachusetts medical schools, is listening to the students talk about all of the encounters they've had in talking with patients about serious illness and not feeling like they had enough time to debrief or talk about those conversations with faculty and staff. It's made me think a little bit differently about how we should create a space for those students, especially when it comes to patients who maybe don't have access to routine medical care. I hope in the future we'll continue to work together and share ideas. As we've gone through this process, we've realized that all of us are having these same challenges when it comes to teaching our future doctors about caring for patients who are seriously ill.
I've been surprised by the power of the data we've gathered. We've identified gaps in our curricula and opportunities to improve. We've heard the voices of medical students who often feel invisible and they want to participate and be trained as better communicators. We can use this data to advocate and create curricula that is required and not optional for all students in our state.
In the midst of COVID, we began and then completed a survey of the bachelor's programs of nursing in the Commonwealth of Massachusetts, and we're so grateful for a strong response from those schools, including 21 of 26 that participated. And very broadly, there were very thoughtful consideration and answers to the questions that we asked about how serious illness care and communication is being taught across the Commonwealth. We found that there was a lower than we imagined uptake of the LNEC resources that exist, but also an incredibly strong interest, enthusiasm, and hope for collaboration through the Mass Coalition to enhance the work that's being done. Our next steps beginning this month are to launch a survey of graduate programs of schools of nursing across the state. We also hope to work with associate programs, and in our next steps, think about nurses that are currently in practice.
This work has further been enhanced because this spring, in fact, the American Association of Colleges of Nursing released their new document, Essentials: Core Competencies for Professional Nursing Education. Hospice and palliative and supportive care is one of the 4 domains of practice. This is very important because this will help us move our educational initiative forward. But in addition, my goal has been that the work that we're doing in assessing what's happening in nursing schools and thinking about a strategy will be a model for other states to do the same and ensure that all nurses in America are receiving some sort of education in palliative care, whether it's by primary palliative nursing or specialty palliative nursing. And it's been really exciting to work with colleagues who are so excited and committed to making this happen.
Oh, that is such great work. I love that video. I especially love being able to hear from the voices of the medical students themselves. There's something different about when you are listening and collaborating to the people that you are trying to affect. For more details on either the nursing schools or the medical schools work, there are again 2 new web pages that are up with a few more details, and we'll be coming back and telling you more about those as some of the results get turned into presentations and papers. Now it is my great pleasure to introduce Zamawa Arenas, founder and CEO of Floetic, a market research firm specializing in supporting public health and mission-driven organizations. And so fortunately for us, our main researcher collaborator for these last 3 years. Zamawa is going to walk us through the major qualitative findings of this year's research. Over to you, Zamawa.
Thank you, Anna, and good afternoon, everyone. It's a pleasure to be with you to present our major qualitative findings. And please note, with the quantitative findings, there will be additional qualitative findings that we will release in the future. Specifically for the qualitative phase of the research, we wanted to humanize the data and get a better understanding of people's lived experiences and what matters to them. We began by engaging with approximately 600 adults from all over the country who we recruited based on census matching. And we oversampled Black and Latinx participants, people with serious illness, people with disabilities, and caregivers. The purpose was to gather insights into strategies, concepts, and communications that can help improve serious illness care with a focus on marginalized communities that you've heard. We designed the study in 2 parts, and we used a mix of open-ended questions, narratives, and scenarios for testing, and again, as a way to understand what's important to people. In June and July, we engaged with research participants over 2 weeks for exploration of experiences that were focused on communications, relationship building, and decision-making. We also tested interactions and concepts in the forms of 12 conversation statements, 4 quality care definitions, and 5 care models. Informed by part 1 findings, in August, we put together part 2 with all new participants. And over a week, we explored survey questions we needed further insight on and tested narratives and scenarios to help zero in on what traditional ACP and shared decision-making calls to action people believe will have the greatest impact on their health and well-being. And I should say that people in the research were very committed. They were very open in sharing their stories with us. It was quite a privilege to be able to be part of their lives during that time. So part 1, we started by asking people to tell us what comes to mind when they think of healthcare. People reflected on their interactions with clinicians, office staff, health insurance representatives. Many thought about their health, their experiences dating back 5, 10, 15, even 20 years, not just the 18 months or so of COVID. And they told us about the good and the bad. They highlighted experiences that have impacted them and shaped their perceptions and expectations of healthcare. 5 themes stood out, and for most people, there's a strong perception that the health system is focused on making profits and money. The dominant belief is that individuals are treated as a number, and the perception of healthcare as an industry, a conveyor belt approach to treating patients, with doctors being obligated to meet quotas, was a recurring theme. There was also a strong belief that the system is to blame for individuals' negative experiences, such as being rushed through appointments, waiting months to get referrals, having care limited by the type of insurance, the high cost of care, et cetera, et cetera. In people's minds, clinicians, office staff, and health insurance representatives are the face of the system. And while COVID exacerbated the negative, many tolerated and accepted the challenges as something to be expected and appreciated how their doctors, clinicians went above and beyond to make them feel safe and being able to be accessible through virtual appointments. There was not a real sense that the COVID had lowered people's trust in the healthcare system. In fact, many were grateful for how they were treated. Empathy was consistently referred to as an essential quality that defines the good and best clinicians and office staff. People also want clinicians to focus on their well-being, not just on the illness, but rather understand other health challenges they face that can aggravate their illness. For example, a doctor treating a heart condition, but not being aware or making an attempt to understand the individual's mental health challenges. We also heard many stories, personal stories of experiences that influence people's trust in the healthcare system and in clinicians. So I'm going to focus on trust next. Trust in the health system constantly goes through a process of trust building and trust eroding experiences. And this happens throughout the entire process of healthcare engagement. People find themselves navigating a dynamic process that involves both the trust building and trust eroding experiences from their interactions, again, with clinicians, office staff, health insurance representatives. This is not a static or unchangeable process. And through it all, what people simply want is to be treated as a human being, not a number. Across all participants, including Black, Latinx, people with serious illness, disabilities, and caregivers, a noticeable contingent told stories of positive care experiences that stemmed from clinicians and office staff showing empathy, kindness, competency, efficiency in making the effort to listen and make them feel as a human being. Good experiences weren't just limited to long-term clinical relationships. Participants shared many micro trust building moments of respect and kindness that can happen all throughout each healthcare setting. When people have trust building experiences, they feel heard and understood. They feel seen as a whole person, not just the illness. They trust that clinicians have their back and get them. And they feel they are in partnership with their doctors and their health team and also involved in decision-making. People also shared myriad of trust eroding experiences. They indicated that some of these were really a mix of discrimination and racism, lack of empathy, poor communication and listening skills, and limited access to care. When trust eroding experiences occur, people feel judged, talked down to, not believed. They get frustrated and anxious dealing with the healthcare system. They feel disregard for their mental health and overall well-being, and they struggle getting the care and supports they need. There is a strong perception that negative healthcare experiences are widespread, while positive healthcare experiences seem to be more isolated and the luck of the draw, as one of the participants said. With these insights, we moved into testing. First, using 12 conversation statements that reflected what clinicians might say in a typical appointment. We wrote the statements based on learnings from our first phase of listening to the community, as Anna highlighted. And here you can see the first sentence of each of the conversation statements. The full statements and the full text are included in your packet. The statements touch on concepts of competence, expertise, collaboration, decision-making, speaking up, cost, and convenience. Participants read through each of the statements and used a highlighting tool to share which words and phrases resonated and which did not for each one of them. We then engaged them in discussion about their feedback, asked them to select the statement that resonated the most and least, and to tell us why. I will next review the statements that are highlighted in bold. We'll figure this out together. I know that healthcare treatments can be expensive. I'm keeping up with the latest research, treatments, and ideas, and your time matters to me. Here you can see an output of the statement and words that resonated most across all participants. People overwhelmingly selected a collaborative approach to care, summarized in this sentiment. We'll figure this out together. We were also able to review responses by Black, Latinx, people with serious illness, disabilities, and caregivers. And in this case, there were no meaningful differences. Across all groups, people worry that disclosing concerns about medical costs can alter or affect the care and treatment options. However, people appreciate and are inclined to trust clinicians who recognize that healthcare treatments can be expensive. They want to be reassured that if they share concerns about cost, their doctor will not withhold treatments and choices that will help them. Expertise and competence play out in nuanced ways. People expect and want expert doctors. However, statements of expertise were often perceived as arrogant, reinforcing the power imbalance and suggesting that the clinician would not be collaborative. On the other hand, statements like keeping up with the latest research convey expertise and a willingness to learn, reinforcing an openness and collaborative approach, which is what people really value. Statements about respecting a patient's time were not necessarily believable. Most people share the common experience of waiting for doctors who are running late or feeling rushed through appointments, so this statement did not resonate. During exploration, we asked participants to tell us what quality care looks like to them, and we used their responses to write 4 quality care definitions and tested each using the highlighting exercise, and people again selected the statement that resonated the most and least and told us why. Overall, people had really strong views about what good quality care looks like. Essentially, what people deeply value is mutual respect, collaboration, and non-judgmental, empathetic care from their clinicians. This sentiment is captured in the top 2 statements. Good quality care is collaborative with me, resonated most overall and with caregivers, and good quality care is kind, empathetic, patient, non-judgmental, resonated most with Black, Latinx, people with serious illness and disabilities. People felt neutral about the definition of good quality care based on competence and expertise because this should be a given. Good quality care as timely, convenient, and coordinated did not resonate, and this was an issue of believability. So what does this all mean? People want partnership, and while timeliness and expertise are important, those are just table stakes. Being treated like a whole person is the real differentiator. It bothers people to try and sell what they perceive to be things that should be basic expectations. Basic courtesies and human decency should not be positioned as a nice to have. This perspective helps explain why people downplayed expertise and competency, which again, they just expect as a given. We also heard from a good number of people who shared their stories of empowerment, how they grew tired of unsatisfactory experiences with their doctor or other health professionals and made a change. Some had done this multiple times over. They were committed to finding a doctor or a practice that met their expectations. For some, doing so meant some trade-offs, and they were willing to have those trade-offs. And those included time, like scheduling appointments with specialists several months out or waiting for doctors running late, all in return for high-quality care, which in their minds is defined as that doctor who treats them as a human being, who shows empathy, truly listens, advocates for them, involves them in decision-making, and ultimately makes them feel better. That is really what matters most. So as we completed this first phase, this first part of the research, we moved into part 2. And for this, here you can see that we had 4 calls to action that we tested. And for this second part, we recruited new participants, about 280 people engaged in this part of the research. And we asked them again to review texts to give us their feedback on words that resonated and words that did not resonate, so that we could, again, zero in on what traditional ACP and shared decision-making calls to action people will believe have the greatest impact in their health and well-being. We split people into 3 communities, and each community saw these call to actions in a different context. The calls to action were about speaking up, pick a proxy, do end-of-life planning, and pick the right doctor. Community 1 saw them all as a public health campaign, and we asked people to imagine seeing these as part of PSAs or posters. Community 2 read them as a part of a simple letter from their doctor's office, and Community 3 read them as part of an expanded letter from their doctor's office, using much of the language about collaboration and empathy that tested really well in July. And let me note that we did not include the call to action, you can look for the right doctor, in the doctor's office letters. This was only viewed by those who participated in the public health test. Like in the previous test, people used the highlighting tool, and in this case, rated each call to action on believability, difficulty, and greatest impact. That you can speak up and have a say in your care call to action was believable and deemed to have the greatest positive impact overall, and especially when presented as clinician communication. It was also perceived as most difficult to do when delivered by healthcare providers and slightly less difficult to do when presented as marketing campaign language. While not difficult to do, you can make a plan for your healthcare. The pick a proxy call to action was deemed to have the least impact and was often associated with getting end-of-life affairs in order. And again, I want to note here that many participants did not seem to think that there was a meaningful difference between these two calls to action. Here you can see the breakdown for the public health campaign treatment. You can speak up and have a say in your care, rated as having the greatest impact for Black and Latinx respondents, as well as people with serious illness. In this case, for people with disabilities and caregivers, the additional option of you can pick the right doctor was seen as the most impactful, although it was perceived as more difficult and less believable than you can speak up. This table shows the breakdown in the doctor's office treatment. All groups selected, you can speak up as the most impactful action in their health and well-being. People nearly unanimously recognize that speaking up about what matters, what works for them, and picking the right doctor is the most impactful and valuable thing that they can do among traditional ACP and shared decision-making calls to actions. But people also know it can be a hard thing to do because the clinician's response is not always in their control, and they can't always switch doctors. And in some ways, their lived reality of negative health care experiences can hold them back. That being said, across our entire qualitative research phase, there was a strong sense that people of all racial and ethnic groups and income levels want to and are willing to speak up, especially Black and Latinx. And the desire and willingness to speak up seems to be increasing as people express feeling more empowered and inclined to question power structures in our country. At the end of the online communities, we asked people to reflect on their participation in the research and share some advice for the coalition. Participants shared that they were inspired to do something new and different given their experience in the online communities. Some gained the confidence and were ready to speak up. Others were inspired by their peers and wanted to search for a new doctor. Others decided that what they had to do was put their end-of-life affairs in order. And for others, it was about time to pick a proxy. They also appreciated that the coalition was asking these questions and that their opinions and experiences might lead to more positive healthcare change, even though it might not impact them directly. And they want the coalition to keep working to prioritize collaborative care and giving patients a voice. I'll end with some advice for the coalition from a participant with a serious illness. Her words capture the sentiments of many of the hundreds of people we engaged. Please keep pushing to make care better for people, to raise your standards and to improve anything you can. Thank you very much, and I will turn it over to Anna.
Thank you so much, Zamoa, and the entire Floetic team. Also a huge thanks to Tony Bach from the University of Washington, who leads the Message Lab project, which supported this work both financially and intellectually. Again, full list of collaborators is in the session resources PDF document along with these findings. So I've seen this data about 500 times at this point, and every time I hear it, it triggers a new thought for me. I think about it differently. I have a new space in my head to interpret, and I know you're all reacting to it for the first time. So we're moving into a place where we have a little bit of time to step back and ask ourselves, what does this data mean to us? What are we going to do with it? What does it suggest about the opportunities and the barriers? I know there were a couple of questions I was seeing in chat. I know Laura was asking about, why we made some particular methodological decisions, like why did you separate end-of-life care planning and get your end-of-life affairs in order from pick a proxy? Some of those are a bit artificial, but bring those questions to the chat and bring them back. If you don't explore them there, we will follow up with them because I think they're really, really good questions, and thanks for everyone paying such close attention. So as fuel for our discussions in our breakout coming up, we are so fortunate to have our coalition co-chair, Maureen Bisignano, President Emerita of the Institute for Healthcare Improvement, share with us a few examples of what it might look like to include what matters to listen to patients in real ways in patient care in the real world around the world. So I'm going to turn it over to Maureen.
Thank you, Anna, and what a joy to be with you all and to kind of celebrate, look back on our progress and to celebrate that, but also to put the challenges that we've heard about this afternoon to work. I'm hearing that people want to understand, they want to appreciate, they want to respect, and they want to act. And so I thought I would share with you a few tools that I've used over the past years to move from what we're learning about what matters most to people and turning that into action. For the past about 20 years, I've been teaching a course at the Harvard School of Public Health every summer. And the one assignment that I've given the students has really had a tremendous impact on them. So I share it with you. I hope you would feel free to use this with your teams as well. But what I ask the students to do is to set aside 45 minutes and to find a person who they can interview who has perhaps a healthcare problem themselves or in their family. And the interview is structured in a very different way, specifically to get the impact I'm intending. What happens is that the students will sit down and they start the interview by saying, what is it like to live with this or to have a child with this? They don't start with anything clinical. They start with the whole person experience. The experiences that the students write about when they start that way are vastly different from anything they've experienced typically in their medical school or nursing public health programs. What they find, as an example, is that they might be interviewing someone who has a child with asthma. And what they find is that the mother or the father will say, well, it's a very big challenge for my son. He frequently has to use his inhaler at school and the other kids make fun of him. So he runs into the back room. He's not making social relationships, or he has to call in sick, or his student's health counselor makes it more difficult to use the inhaler. That matters to the parent is that oftentimes they'll say they have to call in sick and they feel that they're going to lose their job and they're the one with the health insurance. Once they have 15 or 20 minutes listening to the humane part of the impact of healthcare, then they go to the healthcare say, and when you go to healthcare, when you get to your healthcare system, what is it like? And the students tell me that it's an abrupt shift from the human side of the impact of illness to the healthcare system, and that they see the gaps. So this little experiment has such a profound impact on the students. I get letters from students years after they've graduated telling me stories that have such an impact because they started practicing in a different way. They went from thinking my responsibility is clinical diagnosis and treatment to my responsibility is understanding this person and what matters most. So I would encourage you to use that. There's another tool that I began to spread after reading an article in the New England Journal of Medicine about 2012. And I was flying over to Paris to do a plenary in the old pre-COVID days. And I read this article and it totally changed my plenary talk on the plane. And I gave everybody there in the audience a challenge. I said, when you go back, don't always ask the patient what's the matter. Ask them also what matters to you. That question then prompted people to go back to their healthcare organizations and settings. And within a week, I started to get stories from Brazil and Portuguese, from British Columbia, from New Zealand and Australia and all over Europe. And people told me it had a profound impact when they shifted healthcare this way. We started a What Matters to You Day, and now What Matters to You has spread to over 50 countries in the world. Several thousand organizations have included this on their whiteboards, and it is the way that they give rounds every single day. If you want to learn more about this, we meet on a monthly call, people from around the world in different languages. You can see at the bottom of the slide, just go to wmty.world and you'll get some of the research impact of this as well. At the Royal Free in London, the staff found that 67% of the time when they asked what matters to you, they changed the intervention that they went in to deliver. 80% said that it changed the way they give rounds, and they are starting to share things about patients that they didn't ever share before. And 90% said that it enhanced the conversation that they're having with patients. What we're finding is that some people say, well, I'm afraid to ask what matters to you because I'm afraid that the patient will ask me for something that I can't deliver. And yet what you find is when you we've started doing research and collecting from around the world, which of these categories the requests fell into. By far, the vast majority are simple but meaningful. A quick example is in a nursing home I've been working with in Norway. One of the patients is incredibly difficult, and every day at staff change of shift, it would be who has to take that man. And one day the staff, when they were doing change of shift, one of the staff members said to the prior shift, "Did anything make you smile on the last shift?" And one of the nurses said, "Yes." And she pointed to that man, and they all looked and said, "He made you smile?" "Yes." She said when she went in to bathe him, she said to him, "What matters most to you today?" And he said, "I want to wear my blue shirt." And she said, "Why do you want to wear your blue shirt?" And he said, "Well, it was my wife's favorite shirt, and she died 2 years ago today, and I want to honor her." So the whole time she was bathing him, they talked about his life with his wife and what they meant. And at the end of the bath, the patient said, "Put me in my wheelchair. I want to go out and talk to everybody out there about my wife." It totally changed him, the way everybody looked at him. That simple question and the blue shirt made such a difference. At the Royal Free that I mentioned, they started asking the staff in COVID time, "What matters to you?" And the staff were talking about how challenging it was. They said, "We're trying to be heroes, but we're not, we're stressed." And so the CEO came up with a couple of things that said that we heard what mattered to them, and she was doing some. One of them was she created Project Wingman. She called British Airways when they were laying off and furloughing a lot of their pilots and flight attendants. All of those pilots and flight attendants, as you know, are very well trained in stress reduction and managing difficult situations. And so all of the pilots and flight attendants came into the London hospitals and they set up first-class lounges, British Airways first-class lounges with coffee and tea and little cakes. And they were staffed 24 hours a day by pilots and flight attendants. The staff, whether they were physicians or nurses or therapists or environmental services people, started coming in theoretically to get coffee. They would say, "Oh, I just need a cup of coffee." But then they would sit down and those pilots and flight attendants would say, "Tell me about your day." The level of interaction between the healthcare professionals and the airline people dramatically helped the staff to get through these stressful times. She set up she said, "What else worries you?" And they said, "We can't get to the grocery store on the way home." So she set up a grocery store, donations from all the stores and the farms in the London area. And every day when the staff were walking home from work, when they were walking through the lobby, she called it the Royal Free, free at the free. They, for 8 weeks, could take 6 free food items home to feed their family. It wasn't everything, but it said, "I care about you, I'm asking what matters, and I'm doing something." During my work over this past couple of years, I've learned something really important from the physiologists, from the physicians I've been working with. And they described for me the importance of empathy. And Zamara was just so great in talking about empathy. Empathy is critical. It means that you see that someone else is in pain. And what happens physiologically is that triggers a part of your brain that makes you feel bad. You see something painful and you feel bad. But when you act with kindness or compassion, when you do something about it, it makes a different part of your brain trigger, and that makes you feel good. You're seeing empathy problems and you're doing something. And so moving to this is really, I think, moving to action is a critical way for us to think about this. So I would say think about what you might do. Our work at the Age-Friendly Health Systems is really helping people design health systems around people who are aging. And one of the 4 M's, mentation, medication, mobility, is meaning, what matters to you. And that has profoundly changed the conversations. Again, there's a link here so that there are so many places that you can start to learn about the impact that compassion and empathy are having together. So as we move on, I know this is very challenging. We've got lots of work to still do here. People still tell me, particularly in times of COVID, that they feel empathy, but they don't know what to do. You might be saying, how do I get a small group of people to test asking what matters to you tomorrow? Or you might be thinking more about the free at the free. Are there structural things? Are there situations that I need to act on as a leader in my system? Or you might be thinking about policy. You might be thinking about what Andrew and Michael were talking about, the impact of policy on racism. So we've got all of these challenges, and we want to put you into breakout groups now so that you can have conversation together, reflecting on what you've heard. These are the 3 questions I'm going to ask you to think about, the 3 topic areas. First, what surprised you most about the findings? What struck a chord? I'm always talking about IQ and EQ, empathy, but also CQ. What made you curious? What did you want to test when you get back? And we know that you're asking questions in the chat. We do want you to surface those. Think about what you might start or stop or continue doing because of what you've heard today. And what changes do we need? Help us to plan our next years in the collaborative by looking at what could the coalition do at these various levels to support the work that you're doing locally. So Anna, back to you to talk about the details.
All right, welcome back, everybody. I think everyone's going to kind of trickle in a little bit. This is unlike our previous breakouts. You guys might remember from last June, where it just sort of cruelly close on you. But I hope all of your conversations were really wonderful. The ones I popped in on and saw some friendly faces were lovely to hear. So you will see I am joined by our 2 coalition co-chairs, obviously Maureen, who joined us before, and now we are so happy to have Atul Gawande, our other coalition co-chair, joining us real life and in person. We didn't know if he was going to be here due to the vagaries of some of the Senate confirmation hearing process, but we're excited to sort of take a few minutes and reflect on what you guys have been talking about in your breakouts before we move into our next session. So reminder, anybody who took notes in your breakouts, please type those into your chat. I've seen a couple of groups reporting like any reflections or questions that you'd like us to discuss. We have about 10 minutes from now. And if we don't get to those questions now, we will at a later date as we put out more of the data coming out of this and hold like for the future sessions. So I'm seeing that one of the first comments that people had, Atul and Maureen, was really about this idea of weathering, really sort of striking a chord with people, sort of saying like, you know, none of these stats were really surprising me, but this sort of sense of weathering really, I think was really resonated. How do you think about this weathering effect, this kind of intersection between complex chronic conditions as they move into serious illness, and why it's important to think about that intersection when we're talking about equity in serious illness care? Atul, can I start with you?
Yeah, I think if you ask people if they are seriously ill, a lot of people who, I mean, first of all, Michael Curry was so powerful, and he was just in bringing it home to going all the way back through history. And then you understand why when you ask, are you seriously ill? People who are objectively seriously ill don't think of themselves that way. I think of my mother, who's at 84 has metastatic ovarian cancer, but plays tennis every day. I mean, table tennis, not ping pong, not on the courts. And she would say she's not seriously ill. I would say she has a serious illness, and that's the weathering, right? What people have gone through over the course of their lives is what they're measuring their experience against. So how do you address that? Some of that is in the definitions we use and understanding that there's a lot of our definitions that incorporate race to begin with, right? Whether your kidney disease or your heart disease reflects, you can have discounts for race that actually pit ethnicities and race against one another in ways that are harmful. But then even further, like the definition that we used of serious illness, it is, do you have these conditions and is your life changing? Is your functionality or is your condition changing in any way? Those are critical elements of making sure that we don't miss the people where weathering is happening, where they just feel, well, this is as good as I can expect. And we can sometimes offer and expect a lot more.
Yeah.
I completely agree, Atul. And I think that when I was listening to Michael talking about that, I was also kept coming back to his idea that we needed to move from a moment to a movement and really create some structures. But I think, as you say, it really comes down to understanding how that person views their own life and their own disease. And I think, therefore, asking first, tell me about your life, tell me about your day, is much more meaningful, and then coming back to the clinical stuff. I think in a lot of ways we've trained patients to be clinically focused. I think we'll ask them a question and they automatically go into their latest blood sugars, or they'll pull out their lab results, as opposed to really telling us about the social determinants and the life they're living. And I think getting at that is really going to help us to change the way that we provide healthcare. I've been thinking a lot about what I'm calling the 4 T's. The first one is tempo. How often do we interact with somebody? If someone says they've got diabetes and we'll say, well, I'll see you in 6 months, the tempo, I think, is not going to affect their daily lives. The second is touches. Do we have to have an in-person meeting or a virtual meeting, or can we text them? There's so many different ways now that we can communicate. The third is teamwork. Do they have to relate the same story over and over and over again? Or can we bring together effective teams? And I was telling my breakout, I'm trying to work with Alex Cora about getting some hints from him on how do you bring together a team of the Red Sox from very different skills and backgrounds and actually help them to win. And then the last is trust. And I've heard that word so often, frequently. So I think maybe if we could redesign the health system around those 4 T's, we might have better understanding of who we're dealing with.
I think the system comment, I'm looking at a bunch of the other comments, and a thread that's going through a lot of them is this interplay between individual clinicians who right now are really burnt out. And I sort of, there's one message you could take away from this being kind of like, just telling me to listen better isn't something, you know what I mean? A, I know that, and B, I don't have the time, resources, incentives, structures. So this interplay between the individual clinicians and frontline workers who are the face of the system for people, but recognizing at the same time that they are part of systems and are facing their own limits in changing what they would like to be able to do. It's so I think we sort of know that, and patients know that in some part of their brains, but I think it is a real tension, especially difficult right now. How do we navigate, for the purpose of our mission, that so many people in our audience right now are, clinical people, that tension between the personal and the fact that we're all part of a system too.
You want to take that first, Maureen?
Well, I'll just say that as I mentioned in my remarks, I think asking what matters to you, to our staff, is critically important right now. Really understanding compassion, and I would tell you a very quick story about an environmental services worker who was called to HR and being told he was going to be fired. And when he went back to the locker room, his team said, "What matters to you?" Because that's what they hear all the time. And he said, "I've been absent too much." They said, "Why?" He said, "Because I have to go to court. I'm going through a difficult divorce and I'm going to lose my child if I don't go fight for him. He's my 5-year-old child and I love him." And all of the staff came together and they said, "We will create a flexible staffing system so that not only you can deal with what you're going through in your life, so can we all." And I think it's that kind of leadership and understanding that's so critical right now.
I think what I'd build off of that to say is there's a couple kinds of things that we ask people to do. One is the kinds of things that actually make your life easier, but you don't expect it to. And I think Maureen's suggestion of, taking a moment to ask what matters to you most. What are your priorities? What are your biggest worries or fears? Those moments of human connection feel like it take an extra moment, potentially are open-ended and doesn't get me through my 15-minute visit, but in fact, allies you with your patient, with your colleague, with your family member, allows you to understand what their goals are, and then makes it you much more effective. And taking that moment actually pays off in the long run. And I think when you feel more effective, you feel less burned out. And there are some things we ask you to do that are likely to work that way. And then there are other things where, you know, it's not helpful if you have to repeat that conversation over and over, and you have to figure out how to do the documentation system, and how do I pass the word along, and how do I make sure the care is aligned, everybody is aligned with the goals of this patient. I need a whiteboard in the room and I want to write it up. Okay, now it's gotten hard. And now you need systems, and you need leaders and managers who are going to take that as their larger goal. And many of you on this call are leaders at one level or another who can make that happen, and think about with your teams how you make that happen. It's critical to addressing and hearing people addressing the equity issues, being able to produce a better result for people. And it happens to make your own patients, your own family members, your own residents much more appreciative and grateful for the cares that's happened. But that depends on the leaders coming together to join with what the folks on the front lines are experiencing.
Oh, there are so many amazing things happening in chat right now, but unfortunately that's all the time that we have for in this section. We have everything written down here, and I think our hope is to sort of like take it all in and continue the conversation. The breakouts are always too short and too long at the same time, and we'll continue. But now we are so fortunate for our last segment to hand over the virtual mic to Atul. As you probably all know, Atul was nominated this summer by President Biden to be an assistant administrator of USAID. He had his Senate confirmation hearing. He had a Senate hearing a couple of weeks ago, and you would not be surprised to know that his testimony was really lovely to read. So you can find the transcript at the Senate Committee on Foreign Relations. If and when he's confirmed, he'll be in DC full time, working on global vaccine strategy, among other things. So in what will probably be his last coalition appearance for at least a little while, we asked him to help us look all the way back and give us some sage words as we move forward together. So with that, Atul, over to you.
Well, that is so sweet to give me this little bit of time, and I hope I'm confirmed things did go smoothly in the Senate hearing, but the process itself is the strangest hiring process you've ever seen. So it can take a long time. But having this chance to reflect with you on what may be my last summit is really a privilege. We've now been at this for over 5 years, and I wanted to sort of think back on that time by acknowledging with thanks Andrew Dreyfus for his leadership. He was the one who really brought us all together to make this happen. And he made it possible with this enduring commitment of Blue Cross Blue Shield of Massachusetts to back this coalition. We started with a couple dozen partners. We're now in the scores and scores of partners across the state. And Maureen Bisignano, you've been a remarkable co-chair with me. We established a simple goal that our mission is to ensure that health care for everyone in Massachusetts is in accordance with their goals, their values, and preferences at all stages of life and at all steps of their care. And in one of our very first annual meetings, we had a presentation that talked about a few lessons that came from examples of major societal change, ranging from being able to reverse the spread of use of tobacco and achieve tobacco control, to marriage equality, to childcare seats. And one of the things that was sobering about it was that the lesson was it takes a lot longer than we like to imagine. 90% of these transformative movements took more than 20 years to see them actually take hold and change the system. The median was 45 years. And that was sobering. It indicated that we had to be able to understand this is for the long haul. On the other hand, it also that evaluation, that analysis, broke down the process and showed that there are ways to possibly shorten it. And the process starts with getting consensus around a shared understanding of the problem. And that alone took many fields 10 or 20 years for people to agree on the problem they're trying to solve. Then it's to create winnable milestones and a compelling message around the problem that you've defined and shared as your goal. Then to make sure you've designed it to achieve a massive scale. You have to drive, not assume demand, and then keep course correcting along the way. And in the midst of all of that, you need a catalyst that's capable of convening people across the board, private sector, public sector, nonprofits, and to provide a measure of truth about the progress you are or are not making. And I want to measure how we've done against those standards, against that understanding. First of all, I feel we have successfully created a coalition that's capable of convening together, and we've convened a growing coalition around a shared understanding of the problem. Our mission is clear to everybody who've joined in, and we've been able to create a catalytic, small, tiny little organization in the middle of it. Second, I think we're getting sharper about the message that we are sending about how to achieve the mission, that we need our systems and people to understand that you can speak up and have a say in your care, as Zamawa said. The milestones are clearer. For people, we're asking, and our systems, that we help them achieve the completion of their healthcare proxies, that they have a discussion of their priorities besides just surviving with everyone, especially if they're seriously ill. And for care providers, whether it's families, residential facilities, or the healthcare system, they have to have these discussions with people too. It's not just that they have those conversations with family. We have to make a system to elicit and document people's priorities that let them have a say in their care. We have to share information on goals across care settings, and then we have to honor those goals and priorities that people set. And I think we're clearer that those are the steps. There's no question that they are hard, and we are advancing in progress, but we have that long way to go. We've been driving demand, and I'd say that our success there has been slower progress. I've been delighted that we've turned the tide, and it's no longer a death panel to talk about these problems and to see this as a priority. It's not yet an outrage that people experience care when this is missing. It should be an outrage, and we have not driven that demand and that expectation yet. You can see in the surveys that people don't expect much from the healthcare system on these ends and need to know that they can expect more. I think that as a catalytic organization, the coalition has done a remarkable job measuring and giving the truth of where we stand. For 5 years, we've seen no advancement in the state, and we have acknowledged that and continued measuring and shown the gaps. But this is the first year that we've really seen advancement ahead of the country. Finally, all of your work is starting to pay off. Proxies are slightly higher now in Massachusetts than in the rest of the country. We're at 37% versus 33%. You saw the remarkable data that the likelihood of a conversation with your clinician about your priorities and about your proxy has jumped from is up from 14% to 32%. And that is ahead of where the rest of the country is, which is at 22%. Now, the equity gap is a real stress test for the system. Our racial, our ethnic, our educational disparities are the places where you look to see if your system is able to lift up. And those gap disparities persist, and they are as large gaps as they've ever been, except in a small few areas. Our serious illness conversations with clinicians have grown overall, but the trust gap in doing what's right for Black people coming for care, for Hispanic people coming for care, and for those with disabilities, that trust gap has been sizable and to some extent has grown, possibly reflecting where we've been in the pandemic. Certainly our conversations have slipped with families and healthcare agents in the pandemic. That is the work to come, and it will be more years of work. But I have to say, Anna, you've been a remarkable leader coming in to take this on. You've sharpened the efforts. You've kept us focused on these as our goals. And that's included your work seeking to expand our leadership council itself and attempt to bring diversity there, which we need more of at that top level, as Michael Curry would challenge us to say, and to set us up for enabling this coalition for the next 5 years and beyond. I'm so proud of this work, and I'm going to be staying closer to it. And when I'm not in U.S. government, I know I'll be coming back to working with you again.
Thanks, Atul.
Back to you.
Oh, well, thank you, Atul, for sending us off with hope and courage. And we so look forward to seeing you on the flip side. And in the meantime, our enormous best wishes for your vital work in DC, if and when you get confirmed. So I have to say, as we're pretty sure we're going to say goodbye to Atul, there's also another goodbye I have to tell you about, Ellen Goodman. Ellen helped conceptualize the coalition back in 2015. She has been on our leadership team ever since, and boy, have we been the richer for it. A Pulitzer Prize-winning columnist, and that is a terrible word to have to say, columnist and best-selling author, Ellen co-founded the Conversation Project in 2012, in part because of her experience with her own mother. She's stepping down from our coalition leadership team this year, having repeatedly failed retirement already, and is working on lots of exciting new media initiatives, most recently a podcast, She Votes, to commemorate the 100-year anniversary of the 19th Amendment and the struggles for true universal suffrage that followed. Over these last 5 years, Ellen shared with us her skill and passion for using the power of story as a driver of social change, the power of people's voices in demanding better from our institutions, and the power of conversation as a means of transforming our experiences. Ellen, thank you so much for all you've contributed to this coalition, to this field, and the peoples whose lives you've touched. We lost count at about a gazillion. Thanks everyone who has been part of our working groups and projects over the years: public policy, medical schools, nursing schools, Team Triangle, COVID visitations guidelines, public engagement, provider education, and Multipulse. We didn't talk much about Multipulse today because we're going to be having some more dedicated sessions coming up, but let me just say, huge thanks to our colleagues in state government at Elder Affairs, Mass Highway, and HHS, who are working so hard to move this very complex project forward and do it right. And the hugest thanks to Eric Frummy at Ariadne Labs and Ellen DePaula from Honoring Choices, who have chaired the Multipulse Committee, and we would not have gotten this far without them. To the coalition staff, our wonderful hodgepodge of part-time interns, people on rotations, practicum students we never let go of, research collaborators who are now like family, but very super especially to Stephanie Chan, our associate director, who made all of this happen. Everyone should be so lucky to have a Stephanie in their lives. Jane Kavanaugh, our Jane of all trades, our program director, and Diane Araya, who supports us all. Also, huge thanks to Harriet Warshaw, former director of the Conversation Project, and Kate DeBartolo, current director. We are better because of you. We benefit immensely from the support of many Blue Cross teams behind the scenes too, including media relations and communications. Our heartfelt thanks to you and to everyone who came today. Anyone who throws parties like this knows you worry most that no one will come, and then you worry that too many people will come, and then you worry all the time in between. But it's been really great to be back together with you, and I cannot wait until it's in person. That's the end, you guys. Have a great afternoon. Bye.